Ryan, can you talk a little bit about how we measure MRD, what the approaches are, maybe some of the pros and cons?
Yeah, so I think probably the most common tool or method used to measure MRD, at least in the United States, is multi-parameter flow cytometry. It's fast, it's relatively reliable. The nice thing about lymphoblasts is they tend to have a relatively unique immunophenotype, so it's relatively easy for our pathologists to pick them out of a bone marrow specimen. The challenge is there's a lot of variability in the quality of the different techniques. So for example, if one were to try to use the COG experience to sort of follow strictly how the data are done, those assays are generally performed, as I understand it, either at the University of Washington Hematopathology Lab, where I work, or at the Johns Hopkins. It's very, very possible that if you're in community practice and are doing a bone marrow exam and sending it for flow cytometry, that it is not going to be of that same sort of reference lab quality. And the sensitivity of it could be 1 or maybe even 2 logs less sensitive. So an MRD negative result in a patient being tested by that modality is certainly not as reliable a result. On the flip side, or on the other side of the pond as it is in Europe, they base a lot of their MRD assessments by PCR. It's a more labor-intense strategy, but it tends to be more sensitive when done in proper laboratories. And they've worked out a system to standardize it and centralize it that we just don't have here in the US. So one exception to that is probably the BCR-ABL quantitative PCR that we can use for pH-positive patients, and a few other examples of fusion oncogenes that we can use for RT-PCR that's probably more reliably sensitive than most standard flow cytometry. The newest modality that we have, which is starting to gain more traction, I think, is using high throughput sequencing or next generation sequencing to look for clone-specific gene sequence in either the immunoglobulin heavy chain or T-cell receptor genes that are unique to the leukemia. And this can often plumb depths another 1 or 2 logs below some of the methods we have right now. You have to have a specimen from the leukemia to be able to identify the sequence, which is not necessarily always an assured thing. And it does take a little bit more of a turnaround time, so it's not a result you can get back as quickly as flow cytometry. Furthermore, there's still quite a bit of work to be done to understand how that test can really be used to make treatment decisions, at least in my opinion. But I think it's certainly an important and potentially useful tool that is hopefully going to become more and more integrated into clinical trials, so we can hopefully use it a bit more reliably.
Ryan, can I ask something really quick? Sure. So with the pH-positive patients, we were somewhat surprised by our result trials that showed the BCR-ABL PCR really had 0 correlation with outcome. Even flow and PCR MRD had pretty poor correlation with outcome, very different than every other BLL patient. In the adult side, do you see a good correlation with BCR-ABL PCR and outcome?
I would say in my experience, and I think this is an area where we have some data but not a lot. My feeling about this, and you guys can certainly chime in and correct me if you have a different take or know some data that I'm not thinking of, but I think the P190 PCR tends to track more closely with particularly our flow cytometry at the University of Washington. They're of comparable sensitivity, at least in my clinical practice. They tend to track pretty reliably. The P210s tend to clear a little bit more slowly. My suspicion for that, and I think there's data that backs this statement up, but it certainly makes sense biologically, is P210 is way more common in CML. And I think a lot of those patients with pH-positive ALL probably have CML underlying it, and maybe they just came to medical attention as sort of seemingly as a de novo pH-positive ALL. And that persistent P210 may just reflect some persistent, like chronic phase CML. But by flow, we're not seeing any lymphoblasts. So the disease that's actually going to get them into trouble faster, the ALL, is actually in a deep remission, but we're still seeing, I've seen patients with 0.5%, 0.8%, 1% detectable by P210, but their flow, which is sensitive down to 0.01%, is negative. So I think, having an appreciation and understanding of that is important, and then certainly for tracking, making sure that you're ordering the right test on subsequent testing. I've definitely seen a few patients where that got mixed up, so.
That's been my experience as well, and I think you're spot on with kind of that assessment.
I think the MRD role in the pH positive is not well, I mean, the point that I think the flow and then the PCR, now another challenging is in the very, very low level of the PCR positivity was sometimes I get 0.0001%, that being at the transcript level, and then the flow is negative. So like, what do you do for these patients? We just don't have a lot of data because most of our data is also driven by pH minus patients getting certain type of a therapy with a different type. It's also kinetics of the response will be different, the time point will be different. So it is a little bit, I think, to your point, it is a little bit challenging which MRD testing to follow. Should I go with the BCR-ABL transcript versus the traditional, the flow that's been validated in other kind of disease setting?
I think one thing that gets underemphasized is the sample and the importance of a good quality sample, trying to get that first pull, to get a good marrow sample as opposed to the third pull or the fourth pull when you're getting a lot of dilution with peripheral blood. I mean, I think we still think that bone marrow is the kind of the gold standard for assessing MRD, certainly in ALL, so I do want to emphasize that, and I think you all, sounds like you agree with me that getting that good quality sample from the bone marrow.
I think that's really key. I'm glad you mentioned it, because especially the time point that where you're making some decision point, I think it's very, very important for the kind of the patient's treatment there too. I think it's a lot of times in some places that you may not be the ones who's doing the bone marrows, you may not have a control over what samples to be taken, or you really need to inform the performer, that whether it's intervention radiologist, that some places are utilizing that to get the bone marrow, or the technicians or the nurse practitioners, whoever is doing APPs and doing the bone marrow biopsies. I think that really needs to be well established. And the quality of the sample is just as important, because if a total dilution of the samples is no longer really relevant, the testing. So I think that's an excellent point.